Difficult access has been also discussed. I think it's a nice rule of thumb to remember that angiograms typically underestimate severity of disease, and CT scans are a much more sensitive measure of the severity of disease than other modalities. And in our institution, if you think about a conduit, you should basically do it. And if you don't abide by some of these quick rules of thumbs, this is what can happen. This is the proverbial iliac artery on a stick. Ascending dissections is another very feared complication. If you read the literature, the scattered case reports that are reported, what can be estimated is it occurs in about 1% of cases, although there's been a lot of chatter about some associations with the different types of devices, different constructs, whether there's a bare stent or a non-bare stent at the top, etc. None of those things have borne out. That it appears to be, by all measures, independent of the device construct and not particularly related to any particular pathology, whether they actually are, you're treating dissections or aneurysms or ulcers or etc. Branch vessel occlusion is an intraoperative technical complication. This is, again, one of my cases where you could see our intent is to place it in zone 2. We did a prophylactic carotid subclavian bypass, and as the stent graft is being delivered, on the interval angiogram, you should have seen 2 vessels, but lo and behold, you only see 1. We have inadvertently covered the left subclavian artery. We did a salvage, so-called chimney stenting from, unfortunately, this carotid subclavian bypass was there, so we just simply went through a brachial stick and placed a stent, thus restoring perfusion to the left common carotid artery. Arch conformation has been mentioned before, and it's gotten a lot of press in the last few years, and a number of the companies have directly addressed this. You heard from Dr. Farber, the new CTAG device that has addressed this very nicely, and this is exactly the issue we're talking about, so-called the stent graft not conforming to the inner curve of the arch. And everybody thinks this only occurs in the arch. In point of fact, it does not. It occurs in anywhere where there is a curvature, and this is exactly dead center in the middle of the descending thoracic aorta. And as you can see, there's non-conformation here. And the same type of pathophysiology that can occur up in the arch can potentially occur in the mid-descending thoracic aorta. Device collapse, again, you've heard previous speakers talk about this, kind of anecdotally, again, related to oversizing, small radius of curvature, etc. And the different treatments or remediations of this problem include a Palma stent and potentially elective conversion. Deployment failure is another issue. I presented these slides about 3 years ago at the VEITH meeting in New York. This is a very unusual complication of one particular device. As you can see, this device has a single-step deployment mechanism, and the entire device should be deployed with this one maneuver. But as you can see, the proximal or the leading edge has failed to deploy while the rest has completely deployed. This is a very serious problem because the delivery system has this nose cone, and there's no way you can extract this nose cone out of there. So you're basically stuck with this endograft up in the proximal thoracic aorta. What to do with this? Well, I guess you could do a thoracotomy, call the cardiac surgeons in, and to take the thing out. That's clearly not an ideal situation. So using conventional endovascular techniques, we're able to sneak an 014 wire right through this just to give you a sense how tight that space is. And 014 wire barely went in. We went in with a 2mm coronary balloon, barely got a little space in, exchanged it for an 035 wire, etc. And eventually, with a 12mm double XL balloon, inflated to about 10 atmospheres, we're able to break the string that was constrained it. Now, if you thought that lightning can't strike twice, what you'll see here is this is the graft that we've been working on for it took about 30 minutes to get this thing open. And what do you see here? You should all notice this happened again. This was in the same case. So, but I had plenty of experience half an hour before going through this, so we got this done in about 25 minutes. So anyway, very unusual. After speaking with the company, it turns out about 7 cases of this have been reported around the world. But you could probably imagine that denominator is a little bit underestimated. Bare stent perforations have also been well recognized. You could see in this particular case, this is a device that has bare stents. And the patient had a small aneurysmal dilation near the proximal thoracic aorta. The dominant aneurysm was in the mid-descending thoracic aorta. We elected not to treat this, but as you can see, at 1 month CT scan, there was a small pseudoaneurysm here, which expanded to a 7-centimeter pseudoaneurysm by 3 months. The reason why it wasn't treated initially was because I failed to recognize this. He came in symptomatic, and fortunately, it was a simple matter to extend this proximally and repair that. Proximal spring flip or eversion, whatever you want to call it, it's the same thing, has been noted with one particular device, and this problem has subsequently been fixed. I applaud the particular manufacturer for very rapidly acting on this and coming up with a mechanical solution to the problem. But this is illustrated nicely in this set of diagrams where where this artist would lead you to believe that this particular device deploys in this type of nice coaxial manner, but in point of fact, it does not. In real life, especially in these sharp curvatures, this particular device has a tendency to flip into itself downward and cause this type of problem. This is one of my own cases where this had occurred. Infolding, you saw some example of this by the previous speakers, again, related to oversizing. This is an example of a mid-descending infolding. This occurred in the case of a dissection, simply because some of the true lumens can be quite narrow, and it can occur in a gross manner as well as so-called micro-infolding. You can see in this kind of a glass model. Component separation is a late complication that's also been well recognized. In this particular example, this is the pre-discharge CT scan. You can see a nice overlap of up to 3 stents illustrated here. And over the period of time, 12 months, 24 months, approximately 1 stent per year of migration has occurred, to the point where at the end of 3 years, although there was no endoleak, there was barely any kind of overlap between the top and bottom stents. And this was recognized before a true so-called type 3 endoleak occurred, and this was repaired in a fairly straightforward manner by a placement of a so-called bridging endograft. Connecting bar fractures is also well recognized, and that is why in a lot of the devices that are coming out in the pipeline now have gotten rid of many of these so-called longitudinal columnar supporting constructs. And this is an example of one particular device that used to have a connecting bar, and subsequently this device has gotten rid of it because it was not found to be necessary. Endograft infection, albeit extremely rare, extremely feared, and that's why compulsive aseptic technique is so vital, and to perform these procedures in an appropriate laminar flow environment, I think, is so critical. So in summary, what can I say about complications? Well, some require prevention and some require active management. Some are device specific, and meaning therapy specific, and some are device dependent. Some are clearly operator dependent. You've seen so many of my own errors here today, and clearly they involve better patient selection, case planning technique. Once again, I bookend this talk as saying it's an equal opportunity hazard, but fortunately they're very infrequent. Thank you very much.